So I don't have my cursor for some reason. So I can't consent to it. I'm perfectly willing to consent to it. I think I'm just going to try and escape. We had this issue once before. Yeah, because now I'm not advancing my slides. So let's see.
You can't find your cursor?
Yeah, I can't find my cursor and my slides aren't advancing.
You have a Mac?
Yeah.
So if you take your fingers and double click on it, or just click on it with 2 fingers.
Look at that. Okay, cool.
Find it?
How do you go back? How do you go back on the slides now? I'm already advanced.
Okay. Well, you should be able to find your cursor if you do that.
Sideways, so I can see what's going on.
No. So do this on the pad? You said like.
Yeah, that's what I do. And I usually then find it because I've been in the same boat numerous times. So I had to like Google it.
Let's see, it's not.
Maybe double click with your 2 fingers. I don't know.
Oh, I'm really cranking through my slideshow. I can see.
Yeah, the class is over. Well done.
Let me see. Maybe we could stop the screen.
Yeah, maybe
share.
stop sharing. Yeah, stop sharing and then go back. Oh, you want me to stop you
I
from
don't know
sharing?
where-
I'll stop
Yeah,
you. I
if
can
we
stop
can.
you.
I don't have.
Maybe on the left side. Try the left side of the pad.
Yeah, you're up. Yeah, that's something. Oh my gosh. Okay. So now I'm back to the start. I still don't have my cursor.
Do you want to send me the PowerPoint and I'll share the PowerPoint for you?
Sure.
Just email
We
it to
do it
me.
last time. Oops.
I think that is
Wait
what
a
we
minute.
did last
No,
time.
I'm good. I just had to hit escape.
Oh,
Okay, so now I'm consenting to recording. And can you guys, what do you guys see? I don't see anybody. I see my slideshow.
We don't see their slideshow.
Okay. Do you want to try sharing now, Zippy?
No, you have to send it to me if you want me to share it.
No. Just share the screen. Let's try share screen again.
You do that. You have to do that. Click share screen.
Oh, I got to escape out of here. Okay, sorry. Oh, there you all are.
Hi.
It's not like I haven't been doing this for 18 months. Let's see. Share screen. All right, we're good?
Yep.
Good. All right. Well, why don't should we just start?
I think we should start. Absolutely. So just welcome everybody. I'm so glad that you're taking the time out of your summer night to join us. Some of you met Aaron Heffernan when we did our last session with him, and we'll talk about that in October. Aaron works at JFS and she is a school social worker and therapist. And we're really looking forward to what we can learn from you tonight, Aaron. So thanks for being here.
Thank you. Thank you so much for inviting me. It's great to be with teachers again. I've been at JFS for coming up on 7 years. My career's been with children. I'm a child therapist. And it was October of 2020 that I last did this with this group. And it was such a different time. This was the slide that I made. The emphasis on my talk last time was how do we support collegial care as a way of responding to the stressors of remote learning and particularly uncertainty, of which there was a whole lot this time back in October. And it was a great group and some great sharing, and I felt a lot of learning. It was just a great experience. So coping together was my frame and the way that I put my ideas together last time. And so I thought maybe now we'll go to hoping together. We have a new uncertainty now, the uncertainty of returning back to school. Many of you have already been back, but the world is reopening. And my talk tonight is about child mental health, particularly during this new round of uncertainty, and how educators and the mental health community can continue our wonderful partnership. Like Sippy said, I'm a school-based mental health. JFS has 2 school-based clinics, so I've had the great joy of working alongside teachers in this work. even during COVID and before COVID. So my objectives is not to do that. My objective is to do that. To invite us to look at the COVID experience through the eyes of a child. I'm going to discuss some current child mental health trends as we get ready for the return to school. And I'd like to present a model that I think is optimal. That is a model of looking at child experience that's been with us since before COVID. That I think will be really helpful for teachers and mental health professionals alike as the world's reopening. And then in my next time we're together, I won't get to it tonight, some practical strategies for joining with children during the new uncertainty as the world is reopening. This will be fun. Okay. So specifically, we have this problem again here where I can't quite read my points. I sort of can. I kind of like seeing people's faces, but I'm going to review this thing that I hope some of you may have heard of called the ACE study. ACE stands for Adverse Childhood Experiences, and I'll summarize that. So I'll say some things about what that is and not pretend as if everyone knows what I'm talking about. It had a profound effect on the way we look at child trauma and adverse experiences of children. It was a study that started in the late 80s and just created a sea change in the way we view child development, and particularly the impact of trauma on health outcomes later on in life. My idea here is that it will be helpful to look at the COVID experience and the return to school as a unique adverse childhood experience. So I'm suggesting that we use the ACE study as a guide for connecting with kids in a way that's child focused during our big return together. Okay. Nope. Sorry, I'm using my pad. Wasn't this fun? Okay, just a quick check-in. It's 7 o'clock, 7:08 on a Monday. And here's this guy talking to you about returning to school when we're all in the middle of summer vacation. So thank you for being here. And I just asked that maybe you take a minute to just sort of check with yourself about your readiness. We did this in our last talk, and if you're really not feeling ready to learn, that's okay. All I ask is that just kind of notice where you are without judgment. Okay. Doesn't seem to matter where I tap on here. This is going to be really annoying. Okay, got it.
Aaron, do you have an arrow button you can push to advance it?
I don't.
Okay.
I got off track with the cursor, but now the arrows are responding. They've woken up, and we can breathe with my arrow keys now. Something you can use in your classrooms, just an invitation from the Harvard Medical School on the way to breathe. And the idea is counting downwards from 5, breathing in 5, 4, and then breathing out slowly 3, 2, 1. So as we get ready to learn, you can breathe in 5, 4, and then slowly 3, 2, 1. You can do that slowly by yourself, maybe just 2 rounds of that. All right. So I thought I would start with a little meditation that you'll do privately in your own mind. This is not a deep meditation. It's just a minute to sort of think about something that I think will set the tone for this idea of how do we support children in the great reopening of the world again, and how do we support children in general. And the way to, I think a really good way to start with that is this thing called a benefactor meditation. And so I'd just invite you, we won't be sharing this, will just be your own private experience. All of us are here together doing meaningful work in the world. And we sit here together because of people who brought us to this place right now a place of learning and a place of sharing together. And I just invite you to privately take a minute, and in this moment, allow yourself to see the face or faces of a benefactor or benefactors who brought you to this moment. And again, it may be more than one person, someone who took a little extra time, someone who dug a little deeper with you to bring you to this place that you are creating change and doing meaningful work in the world. Benefactors can be protectors and nurturers. Maybe it was a professor, a family member, a non-family member, but to allow that person or people to be with you in this learning experience today, because we'll refer back to them at the end. So we invite them. You might even allow yourself to feel some gratitude for that person or those people who will be alongside us. All right, I'd like to start with a story. Last time I did this, it was a story about a boy I called Noah. This is a story about Joey. And again, a way to invite us to be looking at the COVID experience and return to school through the eyes of a child. I mentioned that I'm in 2 school-based clinics, and one of the clinics I'm in was in a school that reopened in April to about a third, maybe 2/3 of the student population was there. And kids were in masks, and the school was just so happy to be back together, teaching and learning, and kids being in the building and just being together again. And I got a phone call from the principal, who had just spoken with a homeroom teacher for a first grade boy. And thanks to the attunement of this teacher and the responsiveness of this principal, who dug a little deeper to get to the story of this child and why he was acting up, they found that Joey was, having issues with peers and making some scary statements about wanting to die, taking his mask off, and saying he wanted to get sick and didn't want to be here anymore. So because this teacher and this principal have a relationship with this boy, they were able to give me some background before I went upstairs to meet with him and help him stabilize. Joey, they told me, had, before COVID, lost a significant close primary caregiver in his family, and then had to cope with that, moving into the COVID experience, being separated from his friends and his routine. And they came to find out that during COVID lockdown, the family suffered another loss from one of the elders a very important elder in their family who died of COVID. And the extra sad piece was that this elder died during the week of Joey's birthday. So I was briefed by these very well-attuned teachers and this administrator, and came up to meet with Joey, who was upset. Someone looked at him the wrong way, or was some simple little trigger. And I looked at him, and he saw this thing around my neck. And this is one of my most powerful clinical tools. You may know that this is a pulse oximeter. It's a little thing I wear around my neck. And it's great because when a kid is upset, they see this around your neck, and right away they want to stick their finger in it. And it calms them down. You push the little light on, and it shows what their heart rate is. So nurses use these, and it's just a great little biofeedback tool that's only like $14 on Amazon. So right away, he sees this thing on my neck. He puts his finger in the thing. We start to breathe together, and he's already calming down. And he sees that his heart rate has different numbers, and that's great. That's what you want. You want a heart rate that has variety to it. He's 87, he's 95, he's 99. And at one point, his heart rate hits 100. And he has a big smile. And I said, yeah, you noticed that your heart rate hit 100. And he looked at me and he goes, is that because I'm happy? And I said, yes, it must be because you're happy. You know, the scientific reason, he has a good heart rate variability, which is a good measure of a kid's parasympathetic nervous system. And so, yes, it was because he was happy. What a wonderful hypothesis for this kid to have, who has been through so much, to think that his heart rate is at this rate, possibly because he's happy at his core. And what a great thing to share. And what a great experience. This is, for me, a powerful illustration of child consciousness. Alison Gopnik, one of my favorite child developmental psychologists, says kids have lantern consciousness. They see the world with a lantern view. Adults tend to have a spotlight consciousness. So here's Joey with this wonderful hypothesis that his heart rate is at 100 beats per minute, possibly because he's happy. So days go on, he's now breathing from his belly, doing all these great mindfulness practices, and we had this great connection. And it's largely because of this attuned care, this attuned teacher, this attuned administrator who dug a little deeper to get to his story and set me up to make this intervention. All right. So some graphs. We know that adults' mental health issues went up during COVID. Depression, anxiety, and substance abuse from January 21 compared to January through June of 19, all went up. We know that COVID had an impact on the mental health of adults, and parents reporting the same thing among kids. So overall worsening of mental health, depression and anxiety, elevated stress for children as well, according to their parents. Parents are reporting, as you see, the highest symptoms that they're reporting is anxiety. And this is during COVID. So parents are anxious and kids are anxious. There also seems to have been an unequal distribution of child mental health distress during COVID. Households that are facing multiple hardships have reported greater distress among parents and kids. This is not just in England, but this is all in countries that report their data, that the mental health symptoms are unequally distributed in our culture. And so what kids are saying is consistent with what parents are saying. Kids are anxious about going back to school. Kids are feeling nervous and depressed. They wonder about how they'll connect with their friends. 4 out of 5 kids are worried as they come out of lockdown. How might I catch the virus? What's it going to be like getting back into a new routine? And how will I stay up with school? All kinds of worry. There seems to be a trend where, at least with young adults, who are reporting more mental health symptoms. And I think that's at first an interesting thing. But perhaps this bothering me. I don't know if you. Oh, okay, and we're back. Mental health is really back in common discussion. Grief, because the collective grief that's all over the world is really being talked about. And so it's my intention to help kind of equip us as educators and teachers as we reopen to have a model of how to address the very pervasive mental health needs of kids that kids are asking about and that kids are talking about. So how can we respond? There's a clear need for pediatric mental health, unprecedented because of the impact of COVID. We have a shortage of behavioral health workforce in our country. So equipping teachers to have language and to have a model of how to respond is something that I am suggesting here. Briefly, I'll just tell a quick story. When I took my daughter for her physical, because she plays sports, our pediatrician did a mental health screen. She said, this is what we're doing now. It's called the PHQ-9, which is a really quick little depression survey that they give kids as young as 9, I believe. And it's great. But what the pediatrician said is, I'm getting all these results from kids who are depressed and have suicidal thoughts, and I have nowhere to refer them. Right now, Children's Hospital has a 1-year wait for therapy. That's not Children's fault. Children's is a great resource in our community. But there's definitely a shortage. And the question is, how do we equip teachers to be able to respond? Is there a model that we can provide you guys with in partnership with us for addressing child adjustment in a way that's personal and child focused? So we're clipping right along here. I suggest there is a model that's very appropriate and very helpful that I hope will take us into the next time I do this talk, when we talk about practical strategies for addressing child mental health needs. And that is this thing called the ACEs study. And I'll spend a little bit of time summarizing what that is. And would anyone want to just sort of, you can just by raising your hand, has anyone heard of this in your professional development or ever heard of this thing called the ACEs study? It stands for Adverse Childhood Experiences. This was a study that happened in the late 80s, and it was based on a discovery that happened by accident that showed the profound health impact on long-term health of child trauma on kids. It's all over TED Talks and has just gone had a profound impact on how we do therapy, on how we do education, and the view of child trauma and its profound impact in our society. It was based on a long study of a huge sample of 17,000 people that looked at the impact of trauma, and was based on a survey of 10 questions that looked specifically at whether there was a parent who was physically abusive, mentally ill, or incarcerated, to come up with this thing called an ACE score. And you'd see this on any TED Talk or anything like that about, what's your ACE score? ACE score is a reflection of the number of adverse experiences in a kid's life that has a profound impact on health. So the ACE study is everywhere. It's really informed. This whole trauma-informed care movement was really powered by this study that was discovered by this guy, Vincent Felitti, who ran an obesity clinic in San Diego, and in the late 80s realized that he was having a humongous dropout rate in his clinic, and he couldn't figure out why. And just like the principal in my school and the teacher in Joey's class, Dr. Felitti dug a little bit deeper. And he dug deeper into the medical records of the patients in his obesity clinic. And he found out that of the almost 300 people in his obesity clinic, almost every single participant had been violated sexually as a child. This very strange correlation between obesity and child sexual abuse came out of this accidental discovery. And he came to find out that everyone in his program said that obesity was a protective factor for them. They gained weight and kept it on because it solved the problem. This led to this long study that again, of these 17,000 participants, that showed that child abuse and neglect and trauma was prevalent in our society, had a profound impact on neurological, biological, and psychological health, and is unequally distributed in our culture. So 66% of the women had experienced abuse or violence in family. Women were 50% more likely than men to have experienced 5 or more adverse experiences in childhood, higher adverse experiences in kids with disabilities and other health needs, higher ACEs with kids of color and children of color, and in homes with multiple stressors. So lots of data on this, that the higher the ACE score, again, the higher the number of adverse experiences, higher rates of depression, drug abuse, heart disease, all of these profound long-term health outcomes when a child has experienced one or more adverse experiences in childhood.
Aaron, can I ask a question about that?
Please jump
So-
in. Yeah.
If there were multiple siblings in a family, and let's say the
Okay.
trauma was not like the sexual abuse of one child, but let's say it was poverty and an abusive parent and the things that would have been affecting all the siblings,
Yeah.
then did they find that all the siblings would tend to have the same
Not
depression and
necessarily,
stuff?
and you're predicting something, a big point I'm going to make, and I really like that point. Your point. No, there are so many factors which impact how a kid responds to trauma, and that's what the initial ACEs study overlooked. And I'm gonna get to that. It's a great point. So please feel free to jump in, anybody. That's a great question, Zippy. So prevalence. So ACEs comes, we find out that how widespread child abuse and neglect is, how profoundly it impacts neurological, cognitive, and social emotional functioning, and how it's unequally distributed among disenfranchised groups in our society. Okay. I can't say anything about this study without mentioning people who have pushed the ACEs study to also include historical trauma, intergenerational transmission of trauma as a significant predictor of troublesome outcomes, negative health outcomes as well. So we can talk about the trauma, but what are some of the societal forces that are at the root of it, and structural racism, the impact of the immigration experience, and intergenerational transmission of trauma that manifest themselves through maladaptive coping strategies among parents that hurts kids. We can just take a breath because this is a lot that I'm putting in. So let's just take a take a breath here. So this study, this ACE study, first of all, you can get the ACE questionnaire anywhere. It's an excellent clinical tool, but it's a tool that teachers can use too, as a quick way of seeing how many adverse experiences a child or family member be going through to explain risky behaviors and mood issues among kids. So anyway, the impact of this study, I kind of said, it lifted the veil on just on the prevalence and chronicity of child trauma in our culture, and this direct correlation between adversity and long-term negative health outcomes, and a clear demonstration of the disproportionate distribution of trauma in the US. There's some shortcomings that Zippy's question really puts into focus here. When we just do a questionnaire about adverse experiences, we don't capture mitigating factors like protective and compensatory experiences that also impact adjustment. So how could we have two siblings in the same household, same poverty, same compromised parenting, and have such significantly different outcomes in their health or in their adjustment? The ACE, the Adverse Childhood Experiences Questionnaire, doesn't capture those things. It just gives us a number. And so I'm bringing us into COVID now. What the ACE study laid the groundwork for was PACEs, which is protective and compensatory childhood experiences that have a profound impact on how kids adjust. Like I said, the ACEs study, the Adverse Childhood Experiences study, is older, and it sort of brought about this other study of protective experience. So when kids experience multiple forms of adversity, the impacts are magnified. Protective experiences may also have a cumulative effect. So this is more than just common sense that having a caring coach or a caring teacher at school is going to mitigate the impact of trauma. There are identifiable changes in brain structure and behavior when a kid has these certain positive experiences in their life. And it was Johns Hopkins in 2019 that was the first place to go into this and propose 7 protective and compensatory experiences that we really hope are going to be in a kid's life that appear to have a huge impact on coping. So I want to take a minute just to read these because I want to instill this in all of us as we get ready in a couple months to be back in school and have conversations with our students and with the kids that we serve. During COVID, were you able to talk to your family about your feelings? Did you have a family that stood with you during this period of adjustment? Were you able to participate in community traditions? Did you feel like you belonged in your school even though it was remote? Were you supported by a friend? Did you have at least 2 benefactors who took genuine interest in your life? And were you protected by an adult in your home? So Johns Hopkins identified these 7 protective factors, which according to the early, so the data is still coming through here, but already this graph's not easy to read. There appears to be, this is a survey of almost 6,200 adults reporting that when you have more positive experiences in childhood, there's a direct correlation to lower depression and poor mental health. So this graph, it's sort of goofy to read, but this smaller graph on chart on the bottom shows really clearly when there's 0 to 2 positive experiences, your depression and your poor mental health index is going to be higher. The more positive experiences, the more you're inoculated or buffered from stuff that happens. So a quick answer to you, Tippy, would be that sibling who may have been in the same household, same poverty, same negative parenting. I would want to know where were they able to, was that sibling who maybe turned out so differently able to talk about their feelings? Did they feel they had someone else alongside them? Did they feel that there were these other resources alongside them? It also could be temperament and stuff that they're born with. But that's the shortcoming of the ACE study that I've been talking about, this review of difficult experiences. When it just stops, and it's not the fault of the ACE study, but when it stops with just a simple score, a simple number, and doesn't dig deeper, when we dig deeper, we get a broader story of a child's presentation. So when we look into the negative experiences that a kid has been through and see it as more than just a checklist, just a raw score that we come up with, and maybe together through our collegial networks, bravely enter into the experience of a child and assess the reality of child abuse and neglect as something that's prevalent and chronic in our culture. We can see broader truths about the reality of protective factors, personal recovery, and healing. So a lot of people, including the National Institute of Health, are wondering about this. Should we look at the COVID experience as an adverse childhood experience? Does the ACE model have something to teach us as we get ready to meet these children where they're at and engage their families and return to school? It seems kind of obvious, of course. The lockdown was pervasive. We had kids experience the loss of caregivers, the loss of family income, maybe changes in housing, social contact, and routine. But child mortality was much lower than with adults, especially the elderly. And is it helpful to think about child experiences as the child response to COVID as an adverse experience? In some ways, based on anecdotal evidence, based on stuff I hear from families and what my colleagues tell me, there were actually some positive aspects to COVID lockdown for some families. Some people talked about improved family dynamics during lockdown. My colleagues who work with chronically mentally ill patients say that when the world shut down, they felt like the rest of the world understood the world they live in. And it was, nice, to feel understood by others. I mean, COVID also really just created this explosion in telehealth where we're able to do doctor's appointments and therapy appointments over Zoom and reach a lot more people. So, we should be careful when we say, was COVID necessarily an adverse childhood experience like child abuse or poverty? Not all child distress is because of COVID. We had poverty, domestic violence, and child abuse way before COVID came along. So we shouldn't assume necessarily that any child mental health issues now are because of COVID necessarily. That assumes a level playing field before COVID. And so it's my hope that, if we think about this new way that we've been looking at child trauma since the late 80s and early 90s, which is honest and brave and looks at the long-term impacts of child trauma, it can be a helpful model. Just as the ACEs study lifted the veil on the prevalence and chronicity of child abuse and child trauma, its impact on health outcomes, so does looking at COVID as an ACE bring attention to the chronic social and emotional impact of COVID and the unequal distribution of child trauma and among disenfranchised groups and the impact. So does COVID impacted disenfranchised groups unequally as well, is what I'm trying to say, among communities of color, in families with children with special health needs, and in families with multiple stressors. I would include that with immigrant families in particular. But I think ultimately the news is hopeful and good. So when the ACEs study is an invitation for us to be brave and go a little deeper into a child's story, just like Dr. Felitti did with his obesity patients, and see their experience as more than just a checklist. It's when we go a little deeper that we learn the protective and compensatory experiences too. It gives us a more holistic picture that can get to the heart of healing and repair in a way that's subtle, nuanced, hopeful, and child-oriented.
Erin, can I ask another question?
Yeah, because I'm almost done. Go ahead.
So I'm just trying to think about when we're back in the classrooms and we're coming together for the first time, and obviously social emotional learning is going to be just as important, if not more important, than it was this past year. So where would you suggest the focus should be if you're talking, and this might be the next session, but maybe you can give us a preview, that in a whole group setting, not a one-on-one setting, would it be better to say what was hard about COVID, what was hard about last year, or what helped you through last year, or both important questions?
I think to be honest with both. Yeah.
Okay.
And I think teachers are brilliant improvisers, right? You deal on the spot with what you see, and based on relationship with kid. I tend to want to lead towards a positive. What helped you and your family last year? If you're in an SEL group and you're talking about the return to school, I think to have space in a group with obviously developmentally appropriate language and to talk about what changed, what stayed the same, what helped your family, what was difficult. So the question about what was difficult means that this is a space in our classroom that can be honest about our feelings when it's paired with the protective factors. So that'd be my suggestion.
And if we notice kids that have less of those protective factors, would it be worth this year trying to help create them? Like if it's somebody who doesn't seem to have the adult they can talk to, that's something that you're working toward creating for them, or
Absolutely. Teachers are benefactors. I mean, that's why we do this, right? It's why we do this work, for teachers to see themselves as benefactors who can take a little extra time to dig a little deeper. And when there's a kid who maybe doesn't have a lot of these paces that I'm listing here, you know, who doesn't say yes to a lot of these things. Doesn't mean the teacher should take it all, should feel the burden all on them. So I'm referring back to my first talk about collegial care, that it's my hope, as you say really well, Tippy, the focus is going to be so much more deep and broad on social emotional learning. I had one school administrator say in April, as kids were coming back, academics come second. You know, we want to respond to these kids' social emotional needs first. I just thought that was a really profound statement. You know, they can't learn if they're still coping with coming out of social isolation. They can't learn if they're still tending to what their family is struggling with at home. So, yes, I think it is a great and positive thing for teachers to see themselves as benefactors who are not alone, but are working alongside the mental health community, your school social workers, your school psychologists, people in your faith community that are here to listen to kids and know that they can be referred. Yes, we don't have enough therapists. There's not enough to go around, but that doesn't mean we can't work together to find ways to reach these kids. And you concluded my talk so perfectly, Tippy. It's my hope that you all see yourselves as benefactors as you move into the fall. And as people who can look into and meet the Joeys of your classroom and see yourself as someone who can dig a little deeper and know that there may be adverse experiences that happen during COVID, as well as positive and compensatory experiences. So some practical ideas on that I will get into in a month or so. Whenever we come back, I think late August we were looking at. My little preview was actually published in, I think, the journal. My supervisor and I did a little piece on empathic listening as a skill we all have and all great interviewers have on how to join with a child and some very simple, down-to-earth practical ways to do empathic listening.
That was in the Milwaukee Journal?
No, the Jewish Chronicle.
Oh, okay, great.
I think that's where it got published.
Okay.
I just made some talking points and then she made it sound beautiful.
Okay. I do have one more question, and then I want to see if other people have questions. But
yeah,
the one about being able to participate in community traditions. Can you give us some examples of what that would be?
I would say synagogue and church and your place of worship. Absolutely. If that's a place of healing and predictability. What I learned from foster parents and for people who done research on foster children, the single most important factor when working with a child with multiple stressors and traumas is predictability. It's like the single most important factor in helping not just a traumatized kid, but predictability and stability. And so what community traditions do, particularly religious traditions, is provide predictability. I see davening as just a wonderful, rhythmic, predictable routine that I think is a beautiful practice for that grounds kids in tradition and in rhythm, and so not just religious traditions, but any community tradition, because so many of our school traditions were uprooted and upended. Now teachers heroically created some incredible routines and ways of creating predictability in the online world when we were doing remote learning, and now are expected to some teach virtually while they're teaching in person. And so I'm so amazed with how teachers have done this to create environments that are familiar while so much has been uncertain. I mean, COVID is the weirdest natural disaster we've had. There's been no clear beginning, middle, or end, just like you would have in an earthquake or a hurricane. You know, it's this ambiguous loss that just sort of the goalposts sort of keep getting moved, you know, and it's created this unique mental health pandemic as well. And when we're dealing with uncertainty, you get strong emotions. So the benefactors in our community, you're doing it already in the way that you create predictability. My therapy office has been the same office with the same Winnie the Pooh and dollhouse than it was before COVID. When you create an environment that is predictable, you do a lot. It's a profound impact on a kid. It's a long way of answering your question, Sippy.
That was great. Are there other people have questions, or I'm curious if you relate to what's being said here, if this is helpful, if you can see these things in the work you've done this year?
I guess the question I would ask is, besides, you know, looking at our kids when they walk in the door at the beginning of the day and seeing how they interact with their peers and seeing how they interact with you in the classroom, like, are they responding to questions? Are they participating? But like, what other activities should we be doing that really like make them feel comfortable or want to share something that's a stressor or something that, I mean, like, obviously we're so excited to like get back in the classroom and start
Yes, I was
teaching
just going there. Yep.
our curriculum, but like, obviously we need to take a step back and almost start over, as if these kids haven't been together and haven't seen each other and haven't met their teacher and haven't this and like what.
Yeah, I think that's an awesome question. I think to start with, I think to lead with your own joy of being back with kids, knowing full well that that's part of the story. I had one colleague who said kids, you know, knocking on her glass of her door was music to her ears, allowing you to experience your joy of being in personal contact with kids is the starting point, in my opinion. And from that, can create in your classroom an environment, a safety and predictability where eventually, and I would suggest organically, can arise a space where questions like, you know, whether, and again, this is developmental, it's got to be developmentally appropriate. This is room for a fifth grader is going to look different than room for a first graders. In say an SEL group or a morning check-in group, again, depending on the age of your kids, to invite stories, lessons from lockdown, you know, or maybe lockdown's too strong a word, but you know, what was it? How was this for you? Open-ended questions are usually the best. Questions that elicit yes or no tend to be conversation stoppers. So questions that start with how and what, and then, you know, working with classroom management to eliminate distractions so that kids hear other kids. And when one kid opens up that their granny died, you know, teachers, because they've built in an emotionally safe room and safe environment, can maybe give some space to that and to take a breath. And we'll know, I mean, teachers do this beautifully. We'll know how to pendulate between dipping into the difficulties of what we've been through while staying grounded in the here and now and the joy that we all feel being back together. That's how you process trauma, is by, you know, opening some of those difficult doors while holding the resources and the protective, attuned caregiver in the same way. So practically, strategies, yeah, I always default to empathic listening, open-ended questions, trying to eliminate distractions to create an atmosphere, and then getting out of the way, you know, letting kids do the talking. I mean, for some, you know, a little more structure might be good, like specific questions of how was lockdown, you know, how was the experience for you? What did you learn? What did you learn about your family? Who would like to share that? And then being ready, when you leave with an open-ended question, to be ready for responses that could open up to some adverse experiences that happened. So you sort of front load that with, what we share here in the class is special for our class. I don't have to say it's like a confidential psychotherapy setting, but I ask that we have an attitude of respect for kids who are sharing, and to create an atmosphere that's safe to do so in. Hope that answers your question.
Thanks, Erin.
Yes, yeah.
Jennifer was asking about how to create that predictable environment, especially for teachers who are just a few hours a week in religious school. I do want to say, I want to hear your answer, but I want to say that I think often we get in a hurry to cover a certain amount of material. And so we rush through some of these patterns and these opening activities and whatever they are that can be our patterns. And I think we need to force ourselves to slow down. And what Erin was saying before about the emotional stuff being more important this year, and then because they can't learn if they're not having the emotional stuff. And so even if it means you get to do 5 minutes less of whatever your regular instruction was, I think creating those patterns are worth it. But I do want to know what you think, Erin.
I think teachers already know how. I mean, I think starting to be honest with yourself, because I speak for myself and I speak for my colleagues in therapy as well. This year turned so much upside down for us. So to be honest, to start maybe with realizing I've been out of my rhythm for 18 months. The things that I do to create predictability and routine in my life have been shaken. The snow globe's been shaken up, right? And I'm now in a process of finding my new routine in the new uncertainty. Maybe starting there and then turning to colleagues for collegial support and sharing stories of effectiveness. That's what we did in our last gathering, was like looking at times that we were effective and sharing that with each other as a pathway to remembering how you already do predictability in your classrooms. I'm not a teacher. I'm not going to tell teachers how to create their predictability, but I mean, I love, with little kids, how you have the stuff on the wall and the bright colors, and the things that you do to create routine and organization and predictability in our own professional lives, where, like Tsippy says, we have a way of knowing how to modulate all of the learning we have to do in order to allow our own emotions to catch up and create a rhythm for ourselves. I would say it would start with us, sharing with each other what the adjustment is like, what's it like to return, as a way back to our own intuitive knowledge that we already have of how to create predictability in our classrooms.
And I think going off of that is so much of it we probably already are doing and aren't thinking about it as a pattern. Like if you start out with your class in Hebrew with Esa Yom Hayom, what day is today? And Ma Mezag Avir Hayom, what is the weather outside? Or you start your class every day with what holiday is coming up, or come give tzedakah, right? Like whatever it is that is part of what you do in your class every week, even if it's attendance you're starting with every week. But some of that predictable stuff, I think that can be helpful. I know that going back into the office, which I'm starting to do, just sitting at my desk and looking at the same stuff was really helpful. And then of course, 2 weeks later, I had to move into a different office and the desk was facing the opposite direction. And I can't tell you how disoriented I was because that little basic stuff was changed. So going back to whatever those patterns were from before, no matter how simple, could really probably be helpful, I think.
I think that's an excellent question, because the things we used to do pre-COVID to create routine and predictability are not always at our fingertips, and the world is different than it was pre-pandemic. And I think that's the $1 billion question. How do we create predictability in the classroom and with a cohort right now of kids who essentially lost a year or less of teaching, who are coming out of being isolated from each other. We don't know yet. But I love your point. And I'm sorry, was this Faye or Molly's question?
That was Jen's question.
Oh, Jen's, I'm
predictability.
sorry, Jen. To go back to your felt sense of joy of being back in personal space with others, whether it's at work or whether it's at cookouts that we can now have with each other, and just to go and ground yourself in that, and in that, from that, I think we can remember how we create routine and predictability.
Aaron,
Yeah, that's the best answer I have.
I really want to thank you. If
Thank
people
you.
want to
Thank
stay on with questions, that's fine, but I want to point out two things. And I put this at the chat but to begin with, but I'm going to put it back in. Aaron started out with a story about self-harm, which thank God had a happy ending. But this Sunday at Friendship Circle Cafe, we are going to have a suicide prevention workshop with Levi Stein from Friendship Circle. I did the one we did in July. It was incredibly powerful. Each of us can save lives just by getting this training and knowing how to respond and what things to look for. So you have to RSVP. We need to make sure we have enough people to do it. But if you're at all interested, please let me know. And the other thing is that Aaron's follow-up session to this is Wednesday, August 18th at 7 p.m. It's going to be online again. The suicide prevention one is in person. Aaron's the next one is going to be online. So and we've got lots of lunch and learns and other things happening this summer, but I really wanted to point those two out. I'm not going to be working the next 2 days, so I will get you the homework assignment and an evaluation, but it's going to be toward the end of the week that I will send that out to you. And Aaron, can you send me the slideshow so I can send it to everybody?
Absolutely. Mm-hmm.
Great. All right.
So that's a lot of content to cram into 45 minutes. I'm grateful for people being here, and I hope this may, again, provide a little bit of a model, a little bit of a context here. Like I said, my field of child mental health was profoundly impacted in the early 90s by this study, and I think it can inform how we move forward together with responding to the next round of uncertainty that our kids are experiencing. So thank you.
So if there aren't any other questions, we'll say goodnight. Thank you to everybody for coming and taking your time out. And I hope all of you are doing self-care this summer and taking some time for yourselves.
Thank you.
Thank you very much.
Thanks for coming, and thank you, Erin.
Thank you. My pleasure.
Thank you.